Hey guys, my name is Cipriano, and for my final presentation today, I'm going to be talking about restless leg syndrome. And so I first wanted to note that when I was signing up for the presentation, just based off of the name, I thought that this was going to be something related to like a hyperactivity disorder, ADHD, something like that. But this is actually a sleep-wake disorder. And I'll go into a little bit more later on in the PowerPoint about like what that is and the diagnostic criteria for this. But so just before we get into some of that, I want to talk about what this disorder is and what it isn't. So, what restless leg syndrome is again a sleep wake disorder, and it's hallmarked by a neurological condition where the sufferers feel a throbbing or pulling sensation in their leg, and the only way to alleviate that is by shaking or moving their legs. And so these symptoms are actually worsened by inactivity, and it gets significantly worse at night, especially when somebody's trying to sleep and they're trying to be still. And so, what restless leg syndrome is not is, that student that's sitting in class and is just kind of antsy who wants to get up, stretch, take a lap in the hallway, or just like shake their legs to kind of, feel less bored. This syndrome is not that. And we know this because a lot of the research that's coming out about the syndrome is that there's actually, a condition where nerves are firing in the legs, and that's where some of these like pulling and throbbing sensations come from. So it's like not that kid who's just sitting in the back of the room, tapping their foot at hyperspeed. Yeah, so I just kind of want to get that out of the way first. And so let's take a deeper look at this syndrome. So, restless leg syndrome, for the diagnostic criteria, it's characterized by an uncontrollable urge to move your legs. And so, this is accompanied by unpleasant feelings, and where the DSM talks about creeping, crawling, tingling, burning, itching, that kind of thing. And as I mentioned before, symptoms get worse during periods of rest, and which is hallmarked by evenings and nights when somebody's trying to sleep. So symptoms also occur, they have to occur 3 times a week for at least 3 months to be diagnosed with this syndrome. And again, sleep is a big part of this syndrome where I mentioned that it's like a cyclical process because somebody loses sleep because they're trying to alleviate the sensations from their legs by moving around, which makes them tired during the day. And being tired is something that exacerbates some of these symptoms. So overall, it's a cyclical process of somebody feeling uncontrollable urge to move their legs because of the sensations that they're feeling. So the course and the prevalence of this syndrome, we estimate that it's about 7 to 10% of the US population that has it. And a lot of people believe that it's underdiagnosed because a lot of people just don't know that this is a syndrome, that this is something to go and get diagnosed for. And so, with that, symptoms occur in both men and women, but women are more likely to have it than men. And again, this kind of goes back to the diagnosing theory of maybe women are more likely to go talk to a therapist or see a clinician about their symptoms. And so, maybe that's why women are more likely to have it. More research still has to be done in that area. So, this syndrome can symptoms can begin at any age, but it typically happens when somebody's older. And there is a genetic component to it. And so we see that genetic components are more likely to be present in individuals that have symptoms before the age of 40. So, in terms of the prognosis, thinking about what is the course of this syndrome, essentially, once somebody starts to develop some of these symptoms, it can be lifelong, but that doesn't mean that it's, a horrible sentence to the rest of somebody's existence. It's a manageable syndrome. And so, again, it typically starts to come up in somebody who's middle aged or older, and these are the individuals who are most severely affected. And a lot of that has to do with the fact that some of the comorbid issues that happen with restless leg syndrome are physical, and that usually happens with somebody who's older, something like arthritis and things like that. And yeah, as somebody gets older, symptoms are typically more frequent and they last longer, which is again why this is a lifelong prognosis, and but it can be very manageable. So, for some cultural considerations with restless leg syndrome, recent research shows that older Caucasian women suffer from this more, actually 4 times more likely than African American women. And they mentioned that this is due to a combination of factors, right? So, we're talking about genetic predisposition, we're talking about iron, in your diet, and this comes up a little bit later in terms of testing. But yeah, if somebody has a lower iron count in their everyday diet, they're more likely to have RLS. And RLS can also manifest because of medication side effects and the likeliness of seeing symptoms for somebody to go get treatment. So talking some bit about the history of the disorder, it was first described by a doctor in 1672, and in a study that he published originally in Latin, it characterizes, it was a sleep study actually, and so what he found was that in some of the patients, there was leapings and contractions of the tendons, essentially their arms and legs, and this restlessness and tossing that he saw as well. And he mentions that because of their like the movement of their arms and legs, that they weren't able to sleep, and he says that this is the greatest torture. He characterized it as a fidgets in the legs, so it wasn't until like more modern times that we've started to call it restless leg syndrome. So what we know about current theories and current research, it has been extensively studied, but still more has to be done. So what we do know is RLS is caused by genetic factors, metabolic factors, and even nervous system factors. So with nerve cells in leg muscles, they kind of like spaz out, and they cause, the throbbing and pulling sensations that people report feeling. And these increased signals are sent back to the brain. But what we're also seeing in RLS patients is a dysfunction in the basal ganglia, which is the section in your brain that deals with like control of your movement and muscles. And so when there's a misfiring and a lack of a brain chemical of dopamine, that's where some of this like throbbing sensation comes from. And yeah, so in RLS patients, they're noticing like a lack of dopamine. And that's pretty important because dopamine helps with muscle movement or smooth muscle movement. And so without that factor, we see like fidgeting and things like that. So for assessments of this disorder, there is no specific test right now for RLS. And so in order to diagnose it, somebody must first go through like physical medical testing to rule out physical health conditions. And once all of those are ruled out, that's when you can move on to the neurological and physical exams. And so this kind of goes back to what I was mentioning before about iron. In patients with RLS, doctors have noticed that they have low iron counts in their blood. And so that's something that you can test to kind of, look at seeing if this is part of restless leg syndrome. And neurological tests, of course, people can sometimes opt for sleep studies where they monitor like leg jolts and brain activity, breathing and heartbeat and all of those things. And again, going back to the idea that this is a genetic syndrome, a lot of times clinicians will ask for a person's medical and family history. So for a differential diagnosis, again, first you have to rule out physical conditions. Is this arthritis? Are these leg cramps? Is it just positional discomfort? Things like that, ruling out those kinds of conditions to see if this is actually a sleep-wake disorder. And so with that, though, the DSM also mentions that it should be appreciated that any of these similar conditions can also occur in an individual with RLS. So to continue our discussion on differential diagnoses, I want to talk about disorders that are comorbid with RLS. So the DSM mentions certain mental disorders, and mainly attention deficit hyperactivity disorder, ADHD, as well as depressive disorders and anxiety disorders. And we see that in about 2 to 3% of the population that suffer from these mental disorders also have RLS. And ADHD is specifically interesting in this case because it's also caused by dysfunctions related to dopamine. And so I think that's really interesting, especially because with RLS, they've seen that individuals that suffer from these symptoms have a lower counts of dopamine and are having issues with their basal ganglia in terms of dopamine. So yeah, just having ADHD as kind of like a comorbid disorder to RLS is really interesting. And again, so going back to some other physical disorders, as mentioned earlier, there's Parkinson's disease, again, iron deficiencies, and obesity as well. So, in terms of treatment, this is a lifelong syndrome. So, once somebody kind of starts to develop these symptoms, there isn't an end all be all cure, but there are many therapeutic options that a lot of people are able to seek and go down those routes and kind of get their life back together. So, the first one is lifestyle changes. So, this is anything from avoiding drinking alcohol and using tobacco to even just increasing their own exercise, massaging legs, and even using heating pads to stop the throbbing. And one of the resources I list at the end of this, one person mentioned that taking a hot bath every night is really helpful for them. And so, yeah, like there are ways to incorporate new things in their lifestyle to diminish some of the awful symptoms that come with RLS. And again, going back to this iron idea, that taking iron supplements are actually one of the first treatments that are recommended by clinicians for people that are experiencing these symptoms. Because again, we've seen that individuals with these symptoms have low iron counts in their blood. So just by taking an increased level of supplements can help stop some of the cramping and throbbing. So, but for some people where lifestyle changes and taking supplements are not enough, clinicians will start to prescribe certain medications. So, the first one would be an anti seizure drug, and this is as effective as dopamine related medication that we see in the next bullet point. But this doesn't have some of the side effects that those do, specifically, nausea and dizziness. So, anti seizure drugs are usually the go to in terms of medication. But for some people, the symptoms are still so bad that they are prescribed opioids and benzodiazepines. And so this helps with finally getting a restful sleep and fixing some of their energy issues. But again, this is typically used as a last resort. And spoiler alert, some of these come in the discussion video that I want you guys to watch for the discussion question, where there's a case study of a woman named Caroline who she does end up having to take opioids to fix her symptoms. So just for just a quick case representation, I created this idea of a woman named Meredith, who is a 55-year-old white woman, and I use those characteristics because that's kind of what we see in terms of the people, the prevalence that suffer from this disorder, where she comes to you saying that she has throbbing and cramping in her legs, which is, hallmarks of this disorder. And, she says that she's generally fit, but that she's been inactive recently, and that's kind of made her symptoms worse, which is what we know to also be part of this syndrome. And so Meredith has gone to her doctors. She doesn't have any signs of anxiety or Parkinson's, but she went to her GP and they found out that her iron levels are a little low, which is again, one of the hallmarks of this disorder as well. And so, but Meredith also says that, she realizes that her sleep patterns have been different recently, mainly due to her symptoms with falling asleep and having restless legs. So, as you can see, like this is kind of a holistic view of, the prevalence of what somebody's experience would be with having this syndrome. So for the discussion, as I kind of mentioned just a few seconds ago, I'd like you guys to check out this video of Caroline where she spoke with Restless Leg Syndrome Foundation members, and her story was featured on their website. And she just kind of talks about her experience with the disorder and how she finally found peace with certain treatments. So after you watch it, I'd like you guys to just discuss, what were you most surprised to learn about with her condition? And were you surprised about anything with her treatment route? Let me know. I'm excited to hear what you guys come up with. And so finally, this is just some additional reading and kind of like a works cited of the research I did for this. So that's it. Thank you guys so much for watching, and I can't wait to see what you all discuss.